to all of you, depending upon your time zone. And welcome to the third of the free three-part webinar series of PHE Trinity Health Electronic Fetal Monitoring Certification Review course. Course presenter is Nancy O'Brien-Abel. If you've not received the handouts, evaluation form, and sign-in sheet for the webinar, you can from Trinity Health's next website. You will find the link in the chat session. Has been approved for 2 contact hours and 2 Category 1 CME. To qualify these credits, you must attend the entire session and return your evaluation forms and sign-in sheet to Tanya Williams in the Insurance and Risk Management Services. You to her at 734-343-5406 or email it to her at her email address. You turn in the forms no later than November 21st to receive credit. Nancy O'Brien-Abel has nothing to disclose, nor do I, Jerry Girardi, or any other planning members. Your phones will be put on mute during the presentation. If you have any questions throughout the presentation, send them via the Q&A screen to the right of your screen. We'll respond to the questions at the end of her presentation. Leave questions to those that are related to today's content only. At this, it's my pleasure to introduce you to our speaker, Nancy O'Brien-Abel. Neonatal clinical nurse specialist with over 30 years experience in caring for women with new and complicated pregnancies. Clinical instructor at the University of Washington School of Nursing and teaching associate in the Department of Obstetrics and Gynecology at the University of Washington Medical School. She's experience and is actively focused on multidisciplinary education and collaboration. Nancy is a nationally recognized speaker and author on fetal monitoring and the care of women in labor and birth. Active member of A1, contributes to various position statements on evidence-based clinical guidelines, and contributes to A1's fetal heart rate monitoring principles and practices books, both in 2009 and the coming edition in 2014. Nancy received her Master's of Nursing on the Perinatal CNS program, University of Washington. She's certified in electronic fetal monitoring and instructor for A1's fetal heart rate monitoring program. Welcome, Nancy.
Thank you, Artie. If everybody can hear me, and Tanya, you will let me know with the chat line if there's a problem in my sound level here. But welcome, everybody, and I hope many of you, this is your third webinar with me in the series. If not, there are 2 prior webinars that we've already conducted. Oh, sorry, I'm a little goofed up here on these. I forgot I put this in. I do not have anything to disclose. We've covered that. So we've done 3 webinars, or 2 webinars already. This is the third. In the first webinar, we talked about the physiologic basis for fetal monitoring. So you can go back and listen to that if you haven't already. In the first webinar, the content is usually the content that most people struggle with regarding the NCC fetal monitoring exam. It's the most foreign to you as far as language. And so if that's of interest to you, you may want to go back and listen to webinar number 1. Its focus is fetal oxygenation and acidemia, and looking at fetal response to hypoxemia, heart rate regulation, specifically sympathetic, parasympathetic, the baroreceptors, chemoreceptors, cardiac output in fetal states, as well as a review of umbilical arterial cord gases interpretation and relating them back to various fetal heart rate tracing. So that's webinar number 1. Number 2, we covered fetal heart rate patterns, interpretation, and then in utero management. Spent a lot of time looking at normal versus abnormal fetal acid base status, brief categories, and then again half the webinar was devoted to intrauterine or in utero resuscitation, a lot of scenarios, and then included in that we discussed uterine tachycystole as well. And now in the third webinar, it's sort of the potpourri of a lot of different things we'll put into it based on the NCC outline. So I have another slide that I'll move to, which will be more specific about what we'll cover today. For additional considerations, I'm going to speak briefly about a lot of different scenarios that we come across from ruptured vasa previa, fetal maternal hemorrhage, abruptio placenta, uterine rupture, second stage labor, and through all of those, we'll talk just a minute or two about the condition and specifically about the fetal heart rate changes we may see, and a case study. I'll throw in some different case studies to make it interesting because I know you like those. And we'll talk then about medications and their effect on fetal heart rate, a little on instrumentation, looking at the various, I know you all know how to read tracings, but looking at instrumentation in the sense of how the monitor actually works, and then looking at fetal heart rate and maternal confusion, some of the overlap that can happen there, fetal arrhythmias, and then we'll wrap up with antenatal testing. Now, I have a message right now from Tanya saying she does not see my slides. I know there was a little issue last week with Lynn not able to see them initially, and she just had to click on something else. So I hope everybody else can see them. I need to know if there's a problem. They're up as we had them at the beginning, Tanya. So I'm assuming they're okay for everybody else. Move ahead.
Nancy, I can view them.
You can. Dr. Girardi just said that he can view them. So Tanya, it may be something that Lydia had also the same problem on the second webinar. So if others can see them, I'm going to proceed. So let's move ahead. It's really interesting, you all. If you've never done a webinar before, from sitting here in a room by myself, talking to my screen with a headset on, and trying to think about what I'm going to say, and then looking at what chat questions or statements come in, and it's sort of confused. So I'm not going to look at the chat for a few minutes, and I'm going to just talk and look at the slides because that's what's important. So let's start off, and we're going to build into ruptured vasa previa. But first, I want to make a few comments about filamentous insertion of the umbilical cord. And many of you have seen this in your clinical experience. This is where the umbilical cord inserts at distance from the placenta, and the vessels traverse the amnion and chorion without the protection of Wharton's jelly. And you can see here in the next slide a different view of the same placenta and filamentous insertion. Now, this becomes, you and I may have a mom's birth and have a baby with, perfect APGARs, everything's wonderful, as in this particular case, looking at this placenta. The baby came out in the back here where the membranes tore spontaneously, none of the vessels were intersected, and everything was perfectly fine. However, and then you may just look at the basin after the baby's, and then you can see this placenta, and they're pretty remarkable to look at and photograph. Now, the concern is when we have this filamentous insertion, and here we're having this drawing, the vessels traversing the membrane and inserting at a distance to the placenta. And if these vessels are in front of the presenting part and over the cervical os, it's called vasa previa. Now, the good news is that these are relatively rare occurrences because they can be catastrophic, because as you can think about this, if these vessels tear, the membrane tears and it tears into one of these vessels, then it's pure fetal blood that you're losing. And with the amniotic fluid, the blood that's in it, bright blood, will be fetal blood that you're actually looking at, and fetuses can exsanguinate. So that's a real concern.
Nancy, this is Jerry Girardi. I'm going to ask you to hold for a second because what I'm looking at on the webinar, there's been no advancing of the slides since the initial slide. And I'm assuming that's what our
problem is.
Viewers are also seeing no advancing of the slide.
I've had this problem before, and I'm advancing here. I'm set up the same way as before. Tanya, help. I don't know what to do.
Are you sharing your desktop?
Yes, it was shared. I'll go into it again. Share my desktop. Montu.
Okay, now I can see it. Before, I only saw the disclosure slide.
I can see it also.
seen the placenta that has no blood in it? Are you on that slide?
Yes. Yes.
Lost everything else, the chat, and I can't see any of that. I guess, Tanya, we can pull that up at the end.
Yes.
Because I don't see any of that. It's all gone away. So everything's disappeared on that sense. Let me to try to pull it here. Let me try to see it. Okay. So let me back up. I feel bad that people didn't see this. These other slides were beautiful. So let me back up just briefly here, and I apologize to everybody listening that we had glitches with the other two, and I apologize if it was something that changed at my end, if that was the problem. So let me proceed. So I start as we did. This is a slide that showed additional considerations, what we're going to cover today. You have that in your handout. And now I'm beeping in my ear, which I've not heard before, Tanya. I don't know what that is.
Just saying they're recording.
Yeah, that's what that is.
All right. Okay, we had no beeping. All right, we're sort of distracted here. Let's start again and get moving here. I have lots to cover. So additional considerations. This webinar number 3, as I mentioned earlier, you have the slide here with the topics that we're going to be covering and also antenatal testing as well in this 2-hour webinar. Started off talking about filamentous insertion of the umbilical cord that many of you have seen. And again, this is where the cord inserts at a distance. You can see this with the vessels traversing the amnion and chorion to the placenta. And this happen. We have very often healthy babies because they birth, as you can see where my friend's hand is in the back, where there's no, they come out where there are no vessels and everything is perfectly fine. The concern is here when we have a filamentous insertion and it is no vasa previa where these membranes with the vessels are in front of the presumed part over the cervical os, and we have concern here is if these membranes tear and they tear into the vessel, we can have fetal exsanguination. And I think this is where we got caught up to where we were before. I'm hearing a lot of noise on my end, so if somebody's not muted. Now seeing this slide here, which is actually a placenta of a baby that was involved with a ruptured vasa previa. Again, the concern with exsanguination, with rupture of membranes. And what I really want to focus on today is, again, looking at the fetal heart rate that we may see with these different conditions. So in literature, you'll read that initially you may see a fetal tachycardia and then a bradycardia, and it may bounce back and forth between this compensatory increase or the catecholamines trying to increase and circulate the fetal blood, and then a few minutes later the fetal heart rate falls into a bradycardia. Maybe by definition they call it brady, but it's really only down for a few minutes, and which would essentially be a little bit of a prolonged cell, and then back up again. And you may see it bounce around a little bit. Ultimately, you'll hear in the literature that it may turn into a sinusoidal heart rate. In my practice for 35 years, I've never seen sinusoidal, but I've worked in centers where we've been able to get in quicker and birth the baby. So you may or may not see that. And the concern, of course, is that the babies need to be birthed very quickly, and it carries with it ruptured vasa previa about a 60% fetal mortality. So again, depending on the center you're in, if you're in a critical access hospital, obviously it's much difficult. It takes much longer time to get these babies out, and they certainly have a higher mortality. Now, just as a reference point, down here at the bottom, this is from Susan Blackburn's physiology book, to understand that the term fetus only has about 80 to 100 ml per kilo. It's not a lot of blood. So when we think about this exsanguination or these vessels, we can understand how quickly the fetus can be compromised and changes in the fetal heart rate, etc. So the case that we will look at, this is a mom who's 6 centimeters at this point. She's plus in her liver, no oxytocin, it's spontaneous labor. She just received epidural analgesia, and she's comfortable. She'd had some narcotics before and a little bit of a decrease in baseline variability, but all in all, it's been up to this point a normal category 1 tracing. And the next slide, a few minutes after midnight, she has spontaneous rupture of membranes. Nurse is at the bedside. She clearly assesses the fluid and notes bright red bleeding in the fluid, and immediately calls for help, and then does measure to promote fetal oxygenation while the team is assembling and they're moving back towards a cesarean birth. And you can see right here the last few minutes before they're in the operating room. This baby is actually birthed 15 minutes post-bleeding when it was first noted. And as you can see how quickly the baby APGARs decreased. We have now here an APGAR of 1 and 3 on this baby. Unfortunately, there were no cord gases, since you're all experts now in interpreting cord gases after the first webinar. There are no cord gases to look at, but you can imagine what they would be. They weren't able to draw blood, and this is really a ruptured vasa previa with the baby requiring transfusions in the NICU. So you may see a sinusoidal or you may not. So, but I think the important point here is if they put you in a scenario kind of question on the exam, to think in terms of if they give you the bright red bleeding and rupture of membranes, to think ruptured vasa previa, and that any of these different heart rate changes you may see. Second area to talk about would be fetal-maternal hemorrhage. And this is such an interesting topic. We could an hour alone just talking on fetal-maternal hemorrhage. However, I'm going to again be very brief in my comments. As many of you know, fetal-maternal hemorrhage is when the fetal blood enters into the maternal circulation, and it can occur with maternal trauma, like with domestic violence or a motor vehicle crash or accident, or invasive diagnostic procedures. However, most frequently, it's without any evidence of a precipitating factor. To look at the literature related to fetal heart rate changes and fetal monitoring, I've listed on this that you may see absent or decreased fetal movement. Present with that's her only primary complaint. And you think of the NSTs we've done for that. I didn't always think about fetal maternal hemorrhage, but I certainly do now. Indeterminate or abnormal fetal heart rate, which would be your category 2 or 3 tracing. And also, it's listed as sinusoidal heart rate. And don't always see sinusoidal with this either, so you may or may not. So it's interesting when we look at this pattern. A few more interesting points. This is the sinusoidal heart rate, which we've already talked about. The visually apparent smooth sine wave undulating pattern, 3 to 5 cycles per minute, and ACOG and NICHD has added 20 minutes or longer, so we can exclude some of the little ones related to physiologic changes. And a little more on fetal maternal hemorrhage. Understand that when you look at the papers related to it, that the clinical incidence really varies widely. They're taught when they talk about the blood volume. You may read a paper, a lot of papers are 30 ml of fetal blood loss, some are 50 ml. There's even papers that talk about 80 ml blood loss. So there's a lot of variation when we talk about this. And rather than talking about blood volume, it would probably be most helpful to think of it in terms of volume of blood lost as a percent of the total fetal blood volume. So think about a 26-weeker. Obviously, an 80 ml bleed in a 26-weeker is much different than an 80 ml bleed in a big 4-kilo baby. So to keep that in mind as well. And then the other factor to keep in mind when we talk about fetal maternal hemorrhage is that volume of fetal blood in the maternal circulation does not reflect the timing or acuity of the bleed, because you really don't know if the bleed occurred over several weeks or just a few hours. And there's a lot of great information about fetal maternal hemorrhage and algorithms that are set forth in management and getting into middle cerebral artery Doppler flow, et cetera, in the Wiley and Dalton paper that came out in the Green Journal of Obstetrics and Gynecology in 2010, and I would refer to that. It's really a nicely done paper. Moving on, I just put in a quick picture of middle cerebral artery Doppler flow, just because some of you may be interested, and I don't think they'll ask about it, and we'll ask questions perhaps about umbilical artery Doppler flow, and I will talk about that at the end of this webinar. But this is just a picture showing normal versus what we see with MCA with fetal or severe moderate to severe fetal anemia. Case, and let's look at the fetal heart rate. The G2P1 at 37 weeks and 5/7 was involved in a low-impact motor vehicle crash about an hour prior. She had per use of 3-point restraint, and the airbag did deploy, and she came into the hospital for observation. The initial tracing for about 20 minutes that you do not see appeared normal. There was moderate variability. There were not any accelerations, but moderate variability, normal baseline rate, and no decelerations. So now looking at this strip, you see the first deceleration, though it's hard to even know to classify this as. It comes out of it, the heart rate, some undulating heart rate here. It recovers and then back into this undulating pattern. And next tracing is continuous here. You can see the development of the sinusoidal heart rate tracing. They made the decision to move back to cesarean birth, and as you can see, baby had APGARs of 4 and 6, was quite pale and required volume infusion and resuscitation, and to the NICU with an extremely low hematocrit. That you can see part of that was volume dilution, but still an extremely low hematocrit. So fetal maternal hemorrhage is obviously a big concern, and most of the time we relate it to a sinusoidal heart rate tracing and fetal anemia. However, you don't always see sinusoidal heart rate tracing, so to be aware of that. The next one I want to speak to is abruptio placenta. As you all know, an abruption is bleeding between the decidua and the placenta. It's reported to be about 1% of all pregnancies, so there's varying degrees of what you may see as far as an abruption and outcome for the neonate. The big concern, of course, is decreased uteroplacental perfusion. We talked about abruptions and this perfusional issue in the first webinar, so I'm not going to go over any of that now. But sufficing to say that there's information in the literature on abruptions, and these are some key points from Creasy and Resnick's Maternal Fetal Medicine. But the fact that while there are risk factors, as I've delineated some of them here on the slide, most abruptions, we have no idea what the etiology is. They just occur. But certainly if a woman comes to us and we see on the prenatal record that she has a prior history of 1 or even 2, it has a greater increase in risk for abruption. So hypertension with chronic, a 5-fold increased risk, and if she has chronic and then additionally preeclampsia superimposed, an 8-fold increased risk in abruptio placenta. And then, of course, cigarette smoking, cocaine, specific crack cocaine especially, blunt abdominal trauma are all additional risk factors. And diagnosis is based on clinical findings, and that's where we come back again to our fetal heart rate tracing, looking at increased uterine activity, either with the using the TOCA with hand palpation or using the IUPC, where we can see changes in resting tone and frequency often, always, but often, and changes in the fetal heart rate. And there's a variety of different changes that are in the literature, which they certainly could ask about on the test, but mostly what people will see will be late decelerations, intermittent, and then recurrent or prolonged deceleration. Again, and it may result in a bradycardia, depending on how long it takes us to intervene. And I'll know KB has a poor correlation, ultrasound poor sensitivity, though it's still sometimes ordered, and management really depends on the severity and gestational age. And again, you can read about this. There's tons of literature out there. So let's get a few strips and just talk about these. This is a G3P2 at 37 weeks, and she comes with a complaint of hits to her abdomen by her significant other. And the nurses here did a great job of monitoring. You can see a beautiful pickup on the uterine channel and the TOCA with this high frequency, low amplitude contractions that are going on here, which we often see with action, and also shown that the fetal heart rate was actually quite normal at the beginning. The baseline's running up there towards 160, but it has moderate variability and excels. However, over the next hour and a half, then developed increased abdominal pain, and the heart rate began to evolve into minimal variability and intermittent late and she had a cesarean birth with a diagnosed abruptio placenta. His case was a patient of mine that I will never forget. This is a G1PO. She's 38 and 1/7 weeks, and at her usual means of arrival, she was a frequent flyer on our unit, and some of you have frequent flyers, I'm sure, and she loved to come via the ambulance, and we see her pretty routinely on the unit. And this particular time, though, was a little different, and she came in with a complaint of stomach pain. She was yelling usual profanity and, laughing out at everybody. But this time she actually liked me. I was one of her favorite nurses. However, this time she was spitting at me and trying to bite me, and it was pretty crazy. And she had, again, to using crack cocaine that day. She had admitted other days as well, but this day we were pretty sure there were other drugs involved. But you see, initially we had a really hard time picking up the fetal heart rate. I know many of you have struggled with as well. Hard to do this, and then finally we could get it into this up down pattern. So it appeared to be there were gradual decels or accels. However, thinking about her whole situation, as soon as we were able to pick up uterine activity, it was clear to see there were late decelerations and frequent contractions that were going on with her abruptio diagnosis made then of abruptio placenta. And over the next couple hours, she had increased abdominal pain, minimal variability, recurrent lates, and she refused a cesarean initially, and then ultimately, and that's why there was such a delay, agreed to a cesarean birth. So if they give you some scenario about cocaine intoxication, and they tell a patient who's writhing around in the bed and difficult to monitor, and perhaps an increased blood pressure, they ask something about that, show a strip, and then ask you, and the differential diagnosis may be cocaine intoxication. So again, trying to give you some different scenarios of the class kind of scenarios that are out there, and also that NCC has used on exams in the past, allegedly. So, and then here's another interesting tracing, just to sort of shake it up, and I wish I could see your faces right now. This is a woman who's in second stage pushing. She's developed vaginal bleeding. There had been none prior to this point. She's extremely comfortable with an epidural. She has no increased pain, and resting tone is soft. The nurse is palpating at the bedside, and initially, and then they put in an IUPC, and resting tone, there's no change. There's still adequate spacing between contractions. However, in the past 2 hours, there was a completely normal tracing, category 1. And then you can see this heart rate changes with the bleeding right here. I'm showing it to you. And some of you may think that's a sinusoidal heart rate tracing. Somebody else may think, oh, well, maybe it's approaching marked variability. Either way, it's concerning. It's a change from what they had seen before with this vaginal bleeding. And in about 15 minutes, she's birthed by low forceps, and they have a 30% abruptio placenta, which in hindsight is really interesting. It's really an interesting to talk about, because there was no change in urine activity, which is often the heralding sign that you and I feel so comfortable with being able to palpate or feel that the uterus is not relaxing, the resting tone's increasing, contractions are getting closer together, sort of the classic pattern with an abruptio placenta. So this was quite different. However, a third of her placenta had abrupted. So again, just sort of an interesting scenario to think about and talk about. But knowing that the heart rate had changed, and there were enough signs that there was something going on that was unusual as she began pushing. And then here's your classic. It's an older slide. It's just such a beautiful slide of a classic of abruption. This is a G2P1, 39 weeks. She's in induction due to her situation with hypertension and preeclampsia, and on top of that, she has a history of prior abruption. So it's almost like, when's it going to happen? And here's a case where the care at the bedside, 3 hours, they had a heart rate with minimal variability and intermittent lates, not a normal tracing. Baby did not have adequate reserve going into this, and then she had a a pretty massive abruption here at this point. Went to the operating room. It took him a little time to get the baby out. You can see the increase in resting tone here with an IUPC and the frequency increase of contractions off to the operating room here. But a baby with metabolic acidemia, as we talked about, again, in webinar number 1. So, again, we talked earlier in other webinars about fetal reserve and the importance of reserve to maximize reserve prior to, some catastrophic event, because we never know when they're going to happen. And that wasn't done so well in this particular case. All right. So let's move on and talk about other complication that may arise, which is uterine rupture. As we all know, uterine rupture can occur in an unscarred uterus, and that was documented by the population-based study that Gregory did for the state of California and was published in 1999. Risk is extremely low, as we all know, but it can occur. So when we talk about uterine rupture, most of us think about it as the most serious complication of a TOLAC or trial of labor after cesarean or VBAC, as it can be life-threatening to both the mother and the neonate. And risk of a clinically determined uterine rupture during a TOLAC is approximately 0.5 to 0.9%, and that's per ACOG 2010. However, new studies and folks are now sort of reporting like 0.5% to maybe 0.3 to 0.5% is what a lot of MFMs are quoting now. And although the absolute risk really varies, and I think that's the important point, and it has to do with, as you know, the type of prior scar or the number of cesareans that she's had, prior cesareans, or whether the mother had a prior vaginal birth, or whether the labor was spontaneous or induced. And in the 2010 paper that Kale et al. Published, they found that labor dystocia after 7 centimeters also for women having a TOLAC was associated with uterine rupture. So there's a lot of considerations that go into this. And the good news is that it's a relatively rare event, and that again, we don't see series that have a lot of patients in them, and historically there's been a mix of studies with uterine dehiscence with a catastrophic uterine rupture, and they sort of get all mixed together in the data set. So that's been a little bit confusing as folks have tried to tease out and understand this. And I've given at the bottom of this slide 2 references that have been quite recommended and advised, and folks have read, which was to understand that the NIH consensus group met in 2010 about VAC, and then following that came out the ACOG Data Practice Bulletin number 115. So those, again, are resources that some of you may be interested in. So think about rupture. The most common presenting sign is a fetal heart rate abnormality, and I'm going to found in about 70% of the cases. And again, these study series are small, but you'll read about recurrent lates, or perhaps veil decelerations that are become recurrent, or a prolonged deceleration. And then ultimately, all of them will talk about how, if the birth hasn't occurred, that the baby will develop bradycardia. So that's really the most consistent finding, bradycardia. However, it's a late finding. So again, if you get asked about heart rate symptoms related to uterine rupture, they could put in the answer any of these heart rate changes would be something that they could list. The other thing to keep in mind is that acute signs of uterine rupture are variable, and they may also include loss of fetal stimulation. A mom may complain of new intense pain. They may often be masked with an epidural. Though I've had patients one patient who said it's a pop, and that's all she goes, it feels like I have a gas bubble. It feels like it's popping. And you all know that there's women who we've heard, or you may have experienced, who talk about sort of a burn kind of feel that may occur. Otherwise, sometimes they don't feel anything. And then vaginal bleeding is not a consistent finding. And some newer studies have looked at changes in uterine patterns, uterine contraction patterns, also being a sign that's been related to the uterus rupturing. So a lot of different things that can be going on, but the most common sign, again, would be these heart rate changes that you and I can see and know about. Let's look at a couple tracings here. I want to do 3 different cases, and the main point is to look at what are the heart rate changes. And the second point of these 3 cases will be, and we'll talk about it at the end of these 3 cases, we'll be looking at the length of time the baby was out and looking at then the outcome of the neonate. So the first one is a Tolac with a G4P3. She has a history of a NSVD and then 2 prior C-sections. Comes into labor with spontaneous labor. She's had a complete normal, we're up to 5 centimeters. No heart rate tracing, category 1, moderate variability, normal baseline rate, no decels, and occasional acceleration of the fetal heart rate. And now she's 5 centimeters. And this was a great candidate. As we know, her chances of success for VBAC are greatly increased by the fact that she comes in with spontaneous labor and has a prior vaginal birth. So everybody was really excited about this case. And though it was consented that if there were changes in the heart rate, they would move back to a cesarean birth. And as you can see here at 5 centimeters, initially a little variable here, and then another one, and then it gets deeper, and the recurrent variables. Slide you can see deeper yet, and they're lasting longer and deeper. And at this point, they call it the physician's present, and really great teamwork here, discussing about what was on, and they decided to move to the operating room. And in fact, she did have a uterine dehiscence, and APGARs on this baby were great, 8 and 9, and everything worked out really well. So quick assessment and movement to delivery, and everything turned out well. Now, here's another one, case number 2, and this one is kind of interesting in the sense that who knows what this physician and nurse were thinking about. They're both in the labor room. So here's the story. This is a mom who has 1 prior scar, and she has had a normal tracing up to about 30 minutes prior to what you're seeing here. And there were accelerations began. Initially intermittent, then they became recurrent. Baby was running about 150 beats per minute with moderate variability. And then what you're seeing here is the beginning of a change where these variables have gotten deeper, but now they're not returning back up to baseline. So you see this variable getting back up to baseline, then you would see it more or less going here into a prolonged deceleration, coming back up, and again going down. Now, throughout all of this, the physician and the nurse are in the room, and they are obsessed with these variable decelerations and deciding that the management of choice would be amnio infusion. And they're obviously not thinking too clearly, and I know some of you are probably chuckling at this, but they just sort of missed the saying, what is it, they can't see the forest through the trees. They are caught up in thinking amnio infusion is what's appropriate to do here. So they're setting up, trying to give a bolus, and then the IUPC, they're having difficulty reading resting tone. So they start to put back on the TOCO. At the same time that all of this is going on, there's another nurse, charge nurse out at the desk, and another obstetrician, and they're looking at the central monitor, and they see this happening, and they know this woman has a prior scar. So they rush to the room, and they open the door, and they ask, "Can we help you?" And the nurse and the physician in the room sort of stared at them like deer in headlights, and they're like, "Oh my goodness!" And they then quickly turned off the Pitocin, which had been running, opened the IV. They did a quick check. She's 7 centimeters, and quickly decided with the mom the decision was to move to a C-section. And you can see the baby going on to a prolonged acceleration that turns into a bradycardia. Now, in this particular case, while they were not sharp on what was going on the slide before and what their movement was, at here they make the decision. At least they move really, really quickly. So the baby is down in a bradycardia for 10, 11 and a half or so, 12 minutes, you can see. And this baby does have APGARs then of 8 and 9, though they seem to think that this baby, at least when it was home, they were predicting a good outcome for mom and baby. This was a complete uterine rupture, and it was repaired. And then the third example I want to give you, third case, and this is far the worst one, and this is a really significant time until the baby's out. But this is one in which was a G4P3 and 38 weeks. And it's pretty much everything you all as nurses and physicians and midwives would know not to do. They pretty much did all of the things you would consider inappropriate practice. And this is one in which she had 3 prior scars, and she was brought in for an induction. They ran PIT up to 26 milliunits of oxytocin. All of these things that we know significantly increase the risk of uterine rupture. They pretty much did all of them, and it was they got her to complete, and she started pushing. They turned off the oxytocin, and about 40 minutes later, the heart rate started to decrease again with initially variable decelerations, prolonged decels, and then moving on into bradycardia. And this is a case that had a very, very serious outcome with ultimately a fetal heart rate that, as we discussed in the first webinar, unable to maintain stroke volume, rapid decompensation of this baby with a heart rate below 60 minutes. And some feel that these are cardiac asystole when you get these, when you're down to 60 beats per minute and you get these like squaring off like this. The heart rate is just not beating at times there. And this is actually a very severe outcome of APGARs of 113 and umbilical arterial pH of 6.63. Probably, I don't know for many of you listening to this, but for me, that's the lowest umbilical arterial pH I've ever seen. So a very, very severe case. I think the take home that I want you to have from this, and I'm sorry it's such a bad case, but the take home are the next 2 slides, which are, and the second I don't have, I just put it in today, or yesterday. The first one here is a famous paper. It's the Lyon paper from 1993, where there's 78 cases of uterine rupture during a VBAC trial of labor, large tertiary medical center with residents and everybody available to help out. And they found, again, and this paper gets quoted a lot and written about, is that when there was a normal appearing tracing, then there was some pro-decel with a uterine rupture, that if there was significant neonatal morbidity occurred when there was 18 minutes or longer till they got the baby out. So there would be the pro-decel, normal-looking tracing, the heart would go down with a prolonged decel, and if they could get the baby out in 18 minutes, these babies tended to do okay. And then they showed, which is what's really important, is that when there was decreased fetal reserve, and then something catastrophic like the uterine rupture occurs, then there was compromise as soon as asphyxia within 10 minutes, as early as 10 minutes from the onset of the prolonged decelerations. And folks have, found this in other studies, and probably the more contemporary paper to look at would be Holmgren's, and this was published in the Green Journal in 2012. And again, looking at uterine rupture and neonates born within 18 minutes had a normal umbilical pH or a 5-minute APGAR score greater than 7, where a longer time was associated with adverse outcomes. So clearly, it's time-related. It's clearly reserve, the fetal reserve going into the catastrophic event, be it a uterine rupture or be it abruptio placenta or what. It's important to think of reserve prior to it, and then again the length of time down. So that's sort of a quickie on a few of those conditions. Now, let's change gears just a little bit here and talk about labor. Now, I mean everybody who's listening is very clear about the phases of second stage labor. So just as a quick review of this slide, we all know that there's a latent or passive fetal descent phase, and this is where women are relatively calm and they don't maybe have the urge to bear down at this point, and the fetus can passively descend into the pelvis without the mom to push. It's just sort of this is where the laboring down concept came by. And it's quite remarkable in those few women that we have that do not have epidurals, where you can actually see this, where a woman who's not blocked, can get to complete, and she might really have a strong urge to bear down until the presenting part triggers that Ferguson reflex, and then she just can't stop pushing. The urge is so strong to bear down, and we've all experienced that. Seen that in our practice. But then that becomes the active pushing phase, and then she just almost can't stop pushing, and we all know that whole thing. So the question here in understanding this whole labor down, and we're going to get into a couple cases here in a moment, has to do, it's more tricky with the women who have regional analgesia or anesthesia, because I know there's a lot of variation between anesthesia providers, and someone can have block and can get to complete and can labor down maybe for 30 minutes or an hour, and then get the urge to push and push very effectively, while others can't. So it's always tricky, and it somewhat has to do with their block and other variables involved as well. So just wanted just a quick review, and then we'll move on into this. Now, when we talk about, I should say also with laboring down, we talked about this the second webinar. Understand that while a woman is laboring down, we follow the Q30 and the Q15 minute time assessment for, because it's considered still first stage of labor, so active phase of the first stage when she's laboring down. So it would be Q30 for low risk, Q15 for risk factors in assessment evaluation of the heart rate trace. And we talked about all of that. If some of you don't know what we're talking about, we covered it in the second webinar. Comes truly in second stage, and she starts pushing. And a couple important things to keep in mind. We have to remember to evaluate the fetal heart rate. And now, so we're in second stage, we fall into the Q5 minutes for risk factors, or Q15 minute without. And again, we talked about this in the second webinar. I think it's really important, again, to emphasize this evaluation of fetal heart rate, because over again, I see where I'm involved in evaluating tracings or doing debriefs in hospitals, or in my own work that I've done in labor and delivery, where I've seen us get to second stage, and we sometimes tolerate tracings, abnormal tracings that we would never tolerate in the first stage of labor. But it's like, oh, she's second stage, oh, the baby will be out soon, and we really need to be careful about that, and use our in utero resuscitation and do what's appropriate and right during our care during second stage. And in addition to evaluating heart rate, we really need to be always evaluating fetal descent as well, because that's an important piece of this whole second stage. And it's interesting in hospitals as to what your this is about evaluating descent. Do you check descent every hour, every 2 hours? There is no standard on it, and so it's really up to our physician discretion. That is an area that needs to be evaluated. There was a litigation case that I'm well aware of that occurred actually in my part of the country a few years ago, that had a woman who went 6 hours, yes, I said it correctly, 6 hours in second stage, and they barely an evaluation of descent. She went the first 3 hours. She came in, she was complete. She requested an epidural. She demanded an epidural. Because she had gone fast with her first labor and never had an epidural, they put an epidural in, and then she told essentially the physician and nurse that she wanted the monitors off and she wanted to sleep. And she was a VIP patient. However, she didn't get the best care because the physician and nurses took off the monitors, and she slept for 3 hours. And then beyond that, the next 3 hours were somewhat of a disaster. So again, just to keep this in mind, descent and evaluation of the heart rate go hand in hand. The other piece that is important that I'm assuming everybody's aware of, and I didn't even write this on my slide, is that we no longer do closed glottis pushing, let's say. Rather, women do open glottis pushing. It's better for oxygenation to the fetus. And there's a lot of literature on this, looking at when a woman does a long Valsalva maneuver, she does that long closed glottis pushing, that there's an increase in interthoracic and abdominal pressures that can lead to decreased maternal blood flow to the uterus, as well as decreased uterine blood flow. And the result of all of this is a decreased blood flow to the intervillous space within the placenta, and a drop in pH and PO2 and an increase in PCO2 and obviously increased risk of a neurologically depressed newborn. So that's why we no longer do closed glottis pushing, but rather that open glottis pushing is recommended. And I'm sure you're all well aware of that. So back to descent, though, I did put this one slide in, and it is, I wish we were in a group and I could see you all and talk with you about this, but it's interesting. When you survey units, and you can think about this amongst they're working with, do you use, for station, do you use +3, 0 to +3, or do you use 0 to +5? And it tends to be, remember that 0 to +3 is arbitrary. You're essentially dividing the distance into thirds. And ACOG about 10, 12 years ago came out saying perhaps we should be using +5, and now you'll see this, like this line came from Gabby's Normal and Problem Pregnancies, their 5th edition in 2012, as well as it's also been given permission in Perinatal Nursing, Simpson and Korean's book, the new book coming that just came out this year that's dated as 2014. So to be +5 is what sort of the recommendations are, because it's 5 centimeters, the distance from the ischial spines, and it's important we all speak the same language on our unit. So something you might want to consider as to we all are doing +3 or +5, or is in fact your my +2, your +1, and it gets very confusing. So we need to speak the same language. So let's go on and look at ICE. The ICE that would be really good in this section would be one that we talked about in webinar 2, which was the pushing every other contraction during second stage. And we've already covered that in webinar 2, so I'm not going to recover that now in webinar 3, but that is certainly another way of managing second stage labor. If you have decelerations, I showed a strip of where mom had significant variables, recurrent decelerations in second stage, and having her push every other contraction over the next 30 minutes, these cells went away, and she actually had a APGAR, I think it was a 7 and 9 birth baby. So you can go back to webinar 2 and look at that as one of those in utero management strategies. Here's a different case, though. This one here is a G2P1, 40 weeks and 3/7. She presents at the unit with a 8 to 9 centimeters, 100%, -1 station with a bulging bag of waters. And she comes walking to the unit, and the tracing is normal. Fetal heart rate's normal, category 1. And within a few minutes, the nurse wants to admit her, notify the provider, and mother essentially demands to get up and go to the bathroom. Now, I know the nurses listening to this are not panicking right now, because some of us have been around or helped out with other colleagues of ours who have had a woman pretty much birthing over the toilet. So we don't want to get into those situations. However, this mom did get up, and I'm going to reassure you, look at this next slide. She returned from the bathroom, and the fetal heart rate was, again, normal, moderate variability, and everything was fine. So all of that's good. So take a deep breath. It's okay. This one was okay. So as this labor progresses, a few minutes later, about 25 minutes later, mom has an epidural placed, and the initial dose is given. And I would like to ask all of you, if you're in groups, are you, is a normal tracing? Are you reassured by this tracing? Do you have any reason to, are you concerned? Why or why not? You think about it for a moment, if you're in a group. I hear you different responses, but some people will say, oh, it's normal variability, I'm concerned. But remember everything we've talked about in the last 2 webinars, that if you go back a slide, we have moderate variability in normal baby, and babies don't just with a snap of the fingers become hypoxemic. So this is just a sleep cycle. We talked about this in webinar number 1, moving from active sleep to quiet sleep. Remember that, from awake to asleep, how most of us usually call it. And this is a baby just going through a normal sleep cycle. And a few minutes later, the physician's in the room, the team's together, the patient, her family, the nurse, everybody's together, and a plan is made. And the physician leading it did a really nice job of discussing it with everybody, that the plan would be she would labor down, and that it would recheck the patient in an hour. And so the physician made a great note, nurses made the same note, and everybody was on board. So baby looks great. as you can see, a couple slides, and then she ruptures membrane spontaneously. So all of you, I'm sure, are thinking about what would you do initially. Hopefully, you're all thinking right now, saying out loud the first thing you're going to do if you're in this situation, and that you would check for cord. And there was no cord, and so the nurse quickly put Mom back onto her side and tried to do some position changes as she's calling for help. The physician's being paged, and she's doing other interventions as a second nurse comes in the room, a second pair of hands to help her to increase oxygenation and perfusion to the fetus, changing Mom's position several times. And as you can see, the fetus recovers, and a physician is soon in the room. But I want you to note something else here. Ever get asked, or I should first say not about the test, it's really about our best practice. So if you're in situations where you have a low heart rate, and I know some of you have noted this before, where you may get this compensatory tachycardia, or you get this compensatory increase in fetal heart rate here, and read that this could be due to a surge of catecholamines, meaning your norepinephrine or epinephrine, or increase in sympathetic activity. We've taught all of this in the first webinar. So if you were asked a question about, some hypoxemic event, or a prolonged deceleration, or something, and with hypoxemia is the word they usually use, and then there's a tachycardia followed by a fetal tachycardia. Now, this is truly not a baseline tachycardia, but they may use that language in the test or in a question, that this would be like a catecholamine or epinephrine, norepinephrine surge, if you get something like that. Right. And then the physician's present, and as you can see, she labors along, again, moderate variability and occasional deceleration. Physician puts in an intrauterine pressure catheter because they're having difficulty assessing uterine activity. They reevaluate, and at the hour mark, the mom really has no urge to push. So, again, the group all discussed it, the family, the provider, the nurse, that the plan would be to continue evaluation and recheck Mom in 3 minutes. Now, some of you are saying the baseline is about 160, 165, and there's minimal variability again. Yes, this baby is going in and out at minimal variability. Yes, the physician's aware of this and the baseline rate. However, it's very reasonable to think 30 minutes, let's reevaluate it. And everybody's following this very closely. A few minutes later, 30 minutes or so, physicians returned. Baseline variability, again, as you can see, is moderate. And she starts putting now, again, as you can see on the far right side, once more a prolonged deceleration. And so the nurse in the room stat pages the doctor, who is really only about 5 feet away, just on the other side of the door, who's right in the room again. And they're doing different maneuvers and place a scalp electrode, and they're off to the operating room. They're there within 2.5 minutes. Excellent documentation takes place of the nurse noting the physician present, the surgical team's present. They note the heart rate's recovered to 150. At this point, the physician, again, they document the heart rate about 10 minutes later, take off the scalp electrode. The physician pulls a few times with a vacuum. However, and the physician notes in his notes that the fetal skull does not move at all. So the decision is to replace the scalp electrode, consent Mom for a cesarean. Fetal heart rate is normal, staying at 150, and prep Mom for a cesarean birth. And in about 15 minutes, where the baby's birthed with normal pH and scars of 7 and 9. So it's an example. You thought I was going to give you bad case, but this is actually a great outcome. It's a well-managed case and well-documented, both from medicine and nursing. And the mom had a cesarean. She was very, very happy that with the whole outcome and with how everything progressed. Everybody in the team was really happy with it. Okay, so now let's move on and talk about medications. I struggle with this section. I don't know what they're going to ask about. However, this particular table was published in the ACOG bulletin in 2009 on interpretation with ICHD nomenclature. They put this table in there. And NCC reproduced this table in some of their educational materials. So I think it's important for your purposes of taking the test to know this table. I don't think the HIV drug is really anything they're going to ask about, but I think everything else it would be important to know about. And I just want to make a few comments about this. Narcotics. We all know a decreased variability. There's, we talked about fusion of narcotics in the first webinar across the cell membrane. Certainly we can see a decrease in accelerations. Stable, sinusoidal. That's usually how they ask it. That's usually the response that they want. Pain, as I'll demonstrate in some practice questions, I believe later on, I have this question in here. I've never heard them from anybody who's taken a test has ever reported to me that they've asked about heart rate. They usually will do something related to cocaine with increased uterine activity. Now, as you know and I know in clinical practice, in real life, we're seeing less and less cocaine use. Really, the big issue is heroin and prescription drugs. But they still occasionally ask a question about also methamphetamines. But they still will ask a question occasionally about cocaine on the exam. Magnesium sulfate, for the purposes of this test, I would think in terms of decreased variability. However, on this one, I want to caution all of you. Go back to the original ACOG paper and you pull any of the articles that are referenced related to mag sulfate, you'll know that there's variation. There are patients who receive mag sulfate and it has no effect on variability, and that the concern sometimes about decreased variability can actually be hypoxemia developing in the fetus due to the disease state, especially if the mag sulfate is being used for hypertension or with preeclampsia. Just to keep that tucked in the back of your head that not always do you see decreased variability. When mag sulfate's running, you can't always say it's just due to the mag sulfate. However, for the purposes of the test, because they put this in a little table, I would keep that in my head. And the methazone, I think everybody knows that it can decrease, beta-methazone doses that we give can decrease variability for the first couple days. Some people will say 2 days. Dexamethasone, we don't know what it does, but beta-methazone clearly will decrease variability, more minimal in appearance. Terbutaline increases baseline heart rate both for mom and baby. We all know that. All right, so let's do a few practice questions for this section that we've covered. First, heart rate pattern likely to develop with severe fetal anemia. Of course, heart rate. Related to this section of our review and on the test, they love to give scenarios. And some of them you feel like you're in a reading test because they're pretty long. I've heard some of the scenarios in the last few months have been super long. The base of the scenario, they give you all the questions. You can't be begging for more information. So here's an example of what they might do. A woman presents to OB triage via the ambulance at 33 weeks gestational age after a motor vehicle accident 35 minutes ago. She was trained with seatbelt, airbag deployed. Vital signs are normal. Her cervix is long, thick, and closed. There's vaginal bleeding. Based on this history and the above tracing, the most important initial assessment is to rule out, and I think Eddie easily would select placental abruption. Question. Most consistent clinical of uterine rupture during trial of labor after cesarean, or they could use the term VBAC, is, and I'm sure all selected bradycardia. Now, they could just as easily, and as I mentioned earlier, put in here recurrent variable decelerations or recurrent late decelerations or prolonged decelerations. So the answer would be something related to fetal heart rate changes. And then a few more. Loss of fetal heart rate variability can result from, this is easy and often how the questions are on tests, obviously medication administration. And then related to scenarios, they will undoubtedly have a question about twins. I can't. You have to just be really carefully assess the strip they give you, but they'll most likely give you a strip. They'll label twin A and twin B and then ask you about the heart rates. And this is pretty much the classic question that they've done, something to this effect, saying the best interpretation of the above tracing is, and you would just have to figure out, that the one twin A is minimal variability, so this would be indeterminate. At twin B, the lighter one has moderate variability. It's running at about 160, the upper range of normal, or it's a little bit above it. But it most likely they pick something like C as the answer. So you can get a sense of you'll have to just look carefully at the question they're giving you. And then I'd add a few more questions. I think those were the ones you had in your handout, but here's a few more. A primip is an early second stage. The rate tracing is normal. Contractions are every 4 minutes, 60 seconds and moderate. The woman has no urge to push. The best initial intervention is to while picking rest or labor down. And then what fetal scalp stimulation during it's appropriate to remember, it's to assess for metabolic acidemia or acidosis during minimal or absent fetal variability. Stimulation is not intervention for the answer B or C. Those would be definitely the wrong answer, and they like questions like this to differentiate those who would do B and C versus the answer A. So our next section we're going to talk about is fetal heart rate instrumentation, and I know this is probably my least favorite area to talk about. However, it's important because we need to think about how the monitors work, and because NCC will ask questions about instrumentation. So just the basics, we all know that the fetal heart rate, when we're specifically talking about electronic fetal monitoring, we're not talking about periodic auscultation that any of you use with your low-risk women. Now, I know in Canada, those of you who are closer to the Canadian border, Canada predominantly uses intermittent auscultation, certainly for all their low-risk women. And I know many hospitals in the United States do as well for low risk. And not many, I shouldn't say many, excuse me, I made a mistake. Many in Canada, some, and few in the United States. I come from a center. We were a multi-center hospital, and our lower risk centers used auscultation. And so when we instituted it in the big manner, there were some nurses who went kicking and screaming. However, we offer it to patients if they're low risk. If that's of interest to them, they feel very strongly about it, we will start with periodic auscultation. And then if there are any changes in the heart rate we hear, and there's a specific protocol to that, then we move to electronic fetal monitoring with the Doppler ultrasound. And so some of you may use protocols like that as well. So this test, though, is specific to electronic fetal monitoring, so we're going to focus on those components. So for fetal heart rate, we have Doppler ultrasound. And then if membranes are ruptured and we need more information, or we're having difficulty picking up heart rate with the Doppler, we put in the internal fetal scalp electrode. And during activity, we have obviously the TOCO dynamometer. We never say that, we just call it the TOCO. But the important point here is it always must be used with finger palpation. There is no way on the TOCO to determine resting tone or intensity of the uterine contraction based on the numbers on the paper. They mean nothing. We have to use fingertip palpation to assess strength and resting tone. Otherwise, we really can't do it. So we need to use our fingertips over the fundus palpating to determine those. And then if we need to use other information, and membranes are ruptured, obviously the intrauterine pressure catheter, or IUPC, can be used. Obviously, the most common combination in the United States presently would be Doppler ultrasound and the TOCO. The next combination is the fetal scalp electrode and TOCO, and then lastly, the scalp lead and the IUPC. Now, I just added this slide. I know you don't have it in your handout, but I starting last night, I want to make sure everybody understands how Doppler works. Most of you, I'm sure, do, but in case you're someone who doesn't, just to understand that when we talk about Doppler ultrasound, the transducer emits high-frequency ultrasound waves that are directed towards the fetus. Okay, it's ultrasound waves that are directed towards the fetal heart. And most of us place it over, we do our Leopold's maneuver, and we place the Doppler over the back of the fetus. It's where we most easily pick up the fetal heart sounds. And these sound waves detect motion, they detect the motion of fetal heart walls, and valves. And these waves are reflected back towards the transducer. And what we now have built into our monitors is something called autocorrelation. It's been since I think the late 80s, 1980s, early 1990s, and people would call these second generation monitors, but they're not really new. We all have them now. And what these second generation monitors have with this autocorrelation is that autocorrelation compares each of these successive waveforms at many points, many more points than the first generation monitors did, to calculate rates. So long ago, for some of you who've been doing this for a long time like myself, remember when the when we used the Doppler variability changed, it looked different when we put on the scalp electrode. Now, autocorrelation, they're much more similar. Variability appears to be similar between the two different devices. So I have this slide in here. It's in your handout, and the real point of this slide is, again, to focus your eye down here about what ultrasound does. Ultrasound, the transducer, it detects motion, the heart wall and valves, compared to over here on the left, where I have down at the bottom, when you listen with your stethoscope. For example, if you take a stethoscope, nobody has the old stethoscope anymore, I don't think, but a stethoscope, and actually listen, what you're hearing are sounds associated with the opening and closing of the ventricle valves. Now, I make sure everybody understands this distinction because they've used these in distractors on a question where they've maybe asked about how does ultrasound work, Doppler work. So I want to make sure everybody understands one is motion, though we hear it. The ultrasound waves is the motion we're looking at. The other is hearing the actual sounds of the opening and closing. So this slide is important because it goes through each of the instruments that we use and a little about them, because I'm sure in their test bag they have a number of questions on instrumentation, and then they randomly pull them out, because I hear people will get like one or two questions related to these each time on the test. So maybe you understand that when you use, if they ask you some question about Doppler ultrasound or autocorrelation, I've just talked about in the last two slides, that it compares the successive reflected ultrasound, Doppler ultrasound waveforms at many points. Well, how does the fetal scalp electrode work? It converts the fetal ECG to heart rate by measuring consecutive fetal R wave intervals, the consecutive fetal R wave intervals. So if you get a long space, we'll get into it in a moment. And the TOCO, it detects changes in the uterine wall shape. That's all it is. A lot of us miss the question on TOCO in practice, because in exam. They think it has to do with kinetic energy or something else, and it's simply just that as the uterus cracks, it balls up, and then the little pressure sensor on the back of the TOCO gets pushed in. So it's really just detecting a change in the shape of the uterine wall. And then the IUPC measures hydrostatic pressure within the uterus, or intraamniotic pressure, and then it converts the pressure into millimeters of mercury. And that's why you and I can read off the paper on the monitor, this is a 50 millimeter contraction, or there's a 75 millimeter strength of uterine contraction, or the resting time is about 15 millimeters of mercury. So we can read it when we use the IUPC. Otherwise, if the toe is used, we have to palpate that the contraction is mild, moderate, or strong, and we palpate whether the resting tone is soft. Okay. About the monitor and instrumentation. Now, I just want to make a few comments on the next slide about signal confusion. And since it's really hard to talk about this interacting with you and knowing what kind of monitors you're using, a lot of different monitors out there. There's different models, there's different years, et cetera. But just to be aware, I'm just going to talk sort of in generalities here of problems that can occur. I think all we can assess, here's the fetal heart rate, here's fetal heart rate, fetal heart rate, fetal heart rate, fetal heart rate. I think probably many of you are concerned about this fetal heart rate. We don't really see moderate variability. We aren't sure what's going on. There's breaks in it. We can't really tell what's happening in some of these areas. We also see a mother who's second stage pushing, and they've put the O2 sat monitor on, and they're running with this oxygen sat monitor. And you can see mom's heart rate with pushing. Now, if you look closely, you see here with pushing or with the acceleration here of mom's heart rate, it looks like you have the fetal heart rate and the mother's heart rate that are almost identical. How interesting. Again, they appear to be almost identical. Here again, and here again. Now, what the truth is about what you're seeing here is probably not accurate as to the fetal heart rate, and there's been some bulletins that have come out about this from the different manufacturers. And the problem here is that if you're getting into the take-home I want you to have is if you're getting into something here that's difficult to read and you're not sure what you're seeing here, a couple suggestions for you. Number one, take off the O2 sat monitor. You don't need to be running with it continuously here. The only reason that the O2 sat monitor would be on is if you're having initiation of the regional block, or some anesthesia providers like to put it back on for maybe 15 minutes with redosing, not all, but some. And then, or if you have a mom who's got severe cardiac or pulmonary, or she's for example, class 3 obesity with issues with sleep apnea, and you've got, and you've given her narcotics, that kind of scenario, that kind of issue where you may be running with the O2 sat monitor. But for most normal women in labor, women don't need to have DIMAPs on their arms, strapped, tied down to the bed, if you will. I'm using that term loosely, but with the DIMAP monitor and with the O2 sat monitor. So there's a problem. It's confounding what you're seeing here. So take it off. Then look at your heart rate, fetal heart rate. If you're having a hard time reading it, we also have a fetal scalp electrode that we can move to unless, she's HIV positive or there's some other reason not to use it. So those two interventions will help clean this up. Unfortunately, in this particular case, they did not, and they continued, and this went on a long period of time. And in fact, this baby was born with APGARs of, I think it was 2 and 4, because they never were able to differentiate. They were reassured, they kept seeing these accelerations that this was fetal rate, but it's just garbage. They have no idea what they're looking at. So again, just be clear about what you're looking at and when you're monitoring with signal confusion. Okay, one thing here about instrumentation that I want to mention to you is looking at maternal respirations on the TOCO. Now, I think all of us know this when we see these up, down, up, down, up, down through a uterine contraction, that this is maternal breathing. I want to clear that we all know this first bullet point, that in no pregnancy, pregnant women have a compensated mild respiratory alkalosis, and that's normal. So if you get to an issue with a mom, and this is my best example of hyperventilation, I didn't have a really good one, but where she's breathing really rapidly, she's hyperventilating, what that will do, it will further enhance her alkalosis and just make her further alkalosis. So be aware of that. So if in fact they ask you a question, they show you a tracing like this, and they ask you what this several contractions you're seeing, and they have this up down kind of thing, and they ask you what it represents, and that's obviously fetal breathing, or the answer could be maternal hyperventilation if they show something like that. And if they ask you or show you a strip like this, or describe a scenario where they talk about a woman who's in, she's frightened and she's in pain, her pain scale's like an 8 out of 10, and she comes in and her pulse is high and her respirations are really high, and she reports dizziness and tingling, and then they ask you if it represents maternal alkalosis, maternal acidosis, or I don't know. I want to make sure everybody understands it's alkalosis. All right, so I've covered alkalosis, hyperventilation, and maternal respirations all on that slide. Now to shake it up a little bit, I know you're going through withdrawal. You need to see another tracing. So here we go. Here's another case that we'll look at. This is G1PO at 40 weeks. Shram, she's in with, she ruptured membranes about 10 in the morning. Comes in with about 1 o'clock now in the afternoon with irregular contractions. She's 1 to 2 centimeters, 60%. As you can see, her vital signs are elevated here and need to be rechecked. So here, initial tracing at 1 o'clock in the afternoon. And here that evening, this is sort of a long strip, that evening about 30 at night. And you can see the tracing, the range when she started, what was it about? 145, 150 beats a minute with variability. Continue to watch this. The next morning, she at 6 a.m. saw the patient. It was documented that she's now 3 centimeters. But I want you to see this tracing and note, I don't see any contractions. There's no note anywhere on the chart other than the cervical exam by a provider, as you'll see throughout this. There's no note by nursing. Other data dumps, it will be clear that she has a dump map on her arm, and there's some data dumps that are going on into the electronic record. There's an occasional temperature being taken, but she is dilating. We'll see that she'll be complete soon, but you can't pick up any contractions. I'll note this fetal heart rate. I know many of you are already like gasping looking at it, but that is not a normal tracing. And it actually looks, variability is decreased from the day before. It's not normal. Here at 10 in the morning, a couple hours later, now you see one contraction or a little bit of stuff going on here on the uterine activity. There is a note, the first note by a nurse with the temperature because it's been taken. And then you can see here a few more contractions that are showing up. But again, this is not a normal fetal heart rate tracing. 2 hours later, she's complete and +1. So somewhere along the way there, she was contracting and they just were not the contractions were just not registering. So here's contracting now, and you can see it, and she's complete and +1 and starts pushing. Now, this is taking 10-minute increments, 12:40, 12:50, 1 o'clock, 1:10, and she's pushing, and now she births her baby. It's a vacuum, a male born, and so the question is to all of you, in looking at this case, what would you say APGARs to be? And some of you are in a room. You can haul up some numbers to each other and try to make a guess, and I respect you for trying to take that risk and make that guess. And some of you are going to be surprised to learn that this baby has 0, 0, 0 APGARs and is dead, obviously. What happened? What was signal confusion? Where did they go wrong? What happened here? So if you go back to that morning at 6 a.m., we look at tracing. We've already ascertained it's not normal. And again, the care is extremely sketchy for this patient. That's 10. Here, 10:10. Complete. Now, it's hard on this one page here. It's hard to know whose heart rate you're looking at here. This looks qualitatively like what the baby looked like, but it's hard to know what's going on here. Pulse previously had been, let's say, 85. So her pulse has been 85. So, you can, this looks fetal and fetal again, but hard to say. You really can't guess what's going on there. Look within 10 minutes what you're seeing here. Seeing heart rate now with moderate variability, and it appears to be accelerations, line of about 120, 130. We don't really have 2 minutes to ascertain, but to get at a baseline here of maybe 130 with accelerations above baseline. Here's an important one I wanted you to see, which was a data dump slide, which again I skipped over to sort of because I didn't want to just to see what any thought of the heart rate. But here's data dump, which automatically went into their record. But I don't know if anybody was even paying attention to this at the bedside. Mom's pulse is 141, and what do we see here? A rate of about 140, where it looks like with accelerations above that 140 baseline. So the mom's pulse that nobody picked up on, and as you can see, it continues here, continues, and now it looks like a heart rate up here towards 180 plus beats per minute. But the baby is born with 0, 0, 0 APGARs. So I'm sorry, so sad, but none of us will make that mistake, right? So very often we see maternal heart rate accelerations with pushing. So if we see something like that, to be well aware of it. Okay, Vaughn, and now talk about cardiac arrhythmias, fetal cardiac arrhythmias. And I still go back to Kleinman's definition. He's written a lot in the various maternal fetal medicine books and papers earlier in his career, and I still think it's a pretty clean definition of any irregularity of fetal cardiac rhythm, irregular cardiac rhythm, or a regular rhythm that remains outside of the general rate of 100 to 160 beats per minute. And yes, he did use 100 there. Not associated with uterine contractions, and periodic heart rate decels are not included. So I'm going to make this discussion really simple, about 5 minutes or so to cover it, and I just focus on three types of fetal arrhythmias. We're going to talk about irregular rhythm arrhythmias, specifically SVT, supraventricular tachycardia, and then bradyarrhythmias, focusing on complete or third-degree heart block. Now, remember that arrhythmias are relatively rare in fetuses. It's reported somewhere around 1 to 2%, 1% as you read different papers. And at 1 to 2%, by far the majority of arrhythmias are irregular rhythm, 90% of that, 1 to 2%. Now, these are either PVCs or PACs. PACs are a little more common than PVCs. However, we no longer really get excited about trying to determine which they are. Now, some of you in your earlier career, like myself, we would run rhythm strip machines, and we'd hook them into our fetal monitors, and we could determine, oh, these are PACs, oh, these are PVCs. But it really doesn't matter for clinical practice in labor and birth. And now folks will call, simply they'll say they're skipped beats. Some people say missed beats, topic beats, or if you want more fancy, you could say intermittent extrasystoles. That's sort of language that most people are using now, missed beats, skipped beats. All right? Now, those occur, we'll come back to them in a moment. Then arrhythmias, 5% of that 1%, and we're going to focus on SVT. We run in the range of, very, very high rate, 40 to 60 beats per minute. Then we'll talk about bradyarrhythmia, specifically complete block, which is way down here, somewhere between 50 to 70 beats per minute. When we talk about irregular rhythm, let me come back up to this and spend a few more minutes on it. It's often picked up in the clinic and natally. You hear this, someone will listen to the heart rate and they'll hear missed beats. They thump, 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 missed beats going on. Most often, practitioners will talk to moms about caffeine intake. Often, caffeine's a player in this, and moms are drinking Mountain Dew, and they aren't really understand that there's caffeine in Mountain Dew, or consuming amounts of chocolate, again, that have caffeine in them. So a discussion needs to take place, and they may come back, a few days later, and the heart rate's back to regular rhythm just due to the caffeine intake. Or they get sent off for echo, and my friends that work in echo are always smiling and laughing because they get all these patients we send over that are completely normal. So, but some way to look at this or determine why there may be an irregular rate. Mom comes in labor. When we put her on the external Doppler, we not have a tracing we can track. There may be a lot of garbage, pen lift, breaks in it, poor pickup. And we just really can't track it. We can hear regular rhythm, but we can't track it. When we put on a fetal scalp electrode, like in this slide, get these upward-downward deflections, upward-downward deflections. Sometimes they come so close together, there's this black banding that occurs, and this has to do with whether it's greater than less than 250 milliseconds, whether you get an upward, downward, or just downward. And I don't think anybody's going to really ask you about that, but that's going on here. They're just these ectopic beats. Here's another slide to show you this particular one. They're all dropped beats. Same thing, ectopic beats. You can see the heart rate baseline through all of this, and then you're just having these ectopic beats. Now, understand that it depends on the monitor that you use. You may use a different kind of monitor. They may look like this, or it may look little short, stubby ones, as you can see on this particular monitor. So they're just these upward, downward deflections, and again, we don't get too excited about them in labor and birth. Now, the one concerned about, we're going to the second one now, is the high rate of supraventricular tachycardia. And it is concerning because it may initially be intermittent, and you may see it. For example, let's say the baby's rate is at 140 beats per minute, and then you'll see the tracing at 140, and then it may jump up to 240 beats per minute for a little bit of time, and the monitor after maybe a minute or two won't like the 240, and it'll drop down to 120. It'll have the rate. So you may see this tracing that has 140, then it may go up to 240 for a little while, then it may drop down to half of 40 down to 120, and it's sort of a crazy looking tracing and difficult to interpret, but that may be happening with this intermittent SVT. Over time, it may become sustained, and again, it'll just sit up there at that 240 to 280 beats per minute. And now, sustained SVT can be very concerning, and on this particular slide, but before I talk about sustain, I'm hopeful work and you all can see it, but I'm going to look here. Oh, I hope this is going to work. I'm hoping this will work. It's not. Why do I get it? Oh, darn it. I have to do this because I have a laser. I was going to show you on this particular fetus, actually SVT. The baby starts off with intermittent and then the heart's color flow. It goes SVT, but I can't do it. I'm sorry, I can't do it. I had a good intention, but I'm not able to show you. But the little heart's pumping along, and then it goes into the SVT, and it's really quite remarkable to look at. But I'm unable to right now. I can't click on any of those things. It's not going to work. Okay, so sorry about that. So sorry. Continuing on, SVT. The concern is when it's sustained, the fetus can develop non-immune drops, and there can be mortality with congestive heart failure. So if SVT is picked up and it's noted in the clinic, the providers will obviously send mom to echocardiography. They look at structure, they look at function, and a lot of decision making goes in. They look to determine whether or not there's high drops developing or not, and if it's sustained. And a whole risk-benefit analysis as to what management will be. Traditionally we used to do a lot more cardioconversion, where we would, if mom's heart was normal, we would bring her in, put her on an EKG monitor and put the fetus on a fetal monitor, and we'd start with the digoxin, and then I've used all of these different drugs here that are listed. We'd use various combinations to try to cardio-convert the fetus in utero. It's not a benign procedure, and there can be complications. So I think operators are so much better now in really looking at our benefit analysis, and sometimes it makes more sense to birth the baby earlier. Sure, we'd like to go to as March of Dimes and ACOG says, the full 40 weeks, and A1, the big campaign now to get to 40 weeks by all the organizations. There are times where a baby may need to be birthed earlier, and certainly big important factors are whether or not there's a presence or absence of high drops, and obviously gestational age. So there's a lot that goes into this. So I think the take home is being able to identify the high rate. It may be intermittent or sustained, and to understand if it's sustained, the fetus there's high mortality, and the baby can develop congestive heart failure. And this is just a baby coming down. We've cardioconverted, and it's the baseline is starting to come down. The moms may be in there for a week and a half as you cardioconvert into your unit. It sometimes takes a while, and these babies may need digestion for the first 6-12 months after birth as well. The last arrhythmia I want to talk about is complete heart block. Some people call it third-degree heart block. Some will say AV dissociation. Most people, though, call it complete heart block. Most current literature, it's complete heart block. This is a situation where you have the atrial rate remains normal. However, the atrial impulses do not conduct to the ventricles, and as a result, the ventricles depolarize at their own intrinsic rate of about 50 to 70 beats per minute. Some people will say as low as 40. Most resources are about 50 to 70 beats per minute, and it'll look just like this. It'll just be pretty much a flat line. You do not see accelerations or decelerations. You do not see moderate variability. It'll just look like this. This is what it'll look like. It really look like a true bradycardia with hypoxia that, usually you see the heart rate going down and trying to come up or go down, or it sits at 60 with some asystole. This doesn't do that. It just is sort of this thing that you're seeing going across the page. Now, here's just showing that the atrial rate may be perfectly normal, but the ventricular rate may be sitting down there at 50. Now, what happens is that there seems to be some type of transplacental passage of maternal antibodies that cause this. So, for example, these babies, I should back up here. There are about half of these babies that have actual structural congenital heart disease and some, but perhaps structural abnormality. And these babies have a very poor prognosis and often die before they would even make it to labor and birth. We would never see them. So this first half I'm not going to really talk about. Let's focus here on the 50% that are associated with maternal antibodies. So in this group, the fetal heart block occurs secondary, if you will, to the transplacental passage of maternal antibodies like maternal anti-Ro or anti-Law antibodies, or a lot of people think about systemic lupus or other related connective disorders. And these fetuses in early embryonic and early fetal development, their hearts are perfectly normal heart, developing perfectly normal conduction. And then these antibodies cross sometime, usually before about 20 weeks gestation. And then this heart blocks. It blocks down, and you get this rate of about 50 to 70 beats per minute. So if you're listening in the prenatal clinic, like let's say you catch tones at 10, 12 weeks, she's in for an appointment at 12, let's say 13 weeks, and you get the heart rate and it's 160 beats per minute, and then she misses her next appointment or her next two appointments, and she comes in, she's 20-some weeks gestation, and you listen now, and the heart rate may be 55 beats per minute, and you're like, what is going on? And you check mom's pulse, and mom's pulse is 88, and you're trying to figure out what's going on. Again, this would be a patient that would be referred over to echocardiography, looking at structure, looking at function. And if these babies have normal structure and they're able to maintain that heart rate up about 55 beats per minute or so, they tend to do well. And then it's just a matter of the provider deciding how they're going to birth them. Most of them now I see birthed by cesarean. I have been involved in 2 cases where the provider birthed the baby. The women did not want cesarean, and these providers aged quite a bit during those labor managements because they had no heart rate tracing to listen to. One patient, we actually turned the monitor off because you couldn't determine anything from this rate just seen right there at 55, 60 beats per minute. And these babies, after they're born, some of them may need pacemaker implantation. And I wanted to put this picture in here, again, just to imprint in your minds in case you come across a question where they ask what happened with heart block, what kind of outcome or what may the neonate need. And they may ask that. And I just wanted you to think in terms of pacemaker by looking at that picture. And then lastly, artifact versus arrhythmia. Really, in real life, in clinical practice, the way that we determine it is we listen. We listen, and if we hear regular rhythm, then with this pen, we know that it's actually artifact. How with an arrhythmia, with ectopic beats or missed beats, we would hear that sound. So let's do a few practice questions here. When using a Doppler to determine autocorrelation, the autocorrelation does what? I read that wrong. What does autocorrelation do? And as you know from what we talked about, it compares successive reflected ultrasound waveforms at many points. The tracing represents, and these distractors of artifact, arrhythmia, or seizure. Well, you can off seizure. It's not seizure. And then you have to decide. And these are those drop beats happening so quickly it makes a band. So this would be fetal arrhythmia. VT increases the fetal risk for sustained T, and that congestive heart failure. And O, detect changes in, about again the shape of the uterine wall. This is very similar to one of the questions that they frequently run, and I can't believe the number of people who come out of the test room who I've talked to because I see the test and have shared with me that they've put down muscle strength or kinetic energy, and they're the answers. So I think we've discussed this enough. I think I went over it for a long enough time today. Fetal high drops may develop with which of the following fetal arrhythmias? Of course, it would be SVT or supraventricular tachycardia. And then two more. Ultrasound Doppler work by detecting, we spent on this, ultrasound by detecting the motion, where asked about the fetoscope, it would be sound of the opening and closing of the valves. Complete block increases fetal risk for, I showed you the image of it, the neonatal pacemaker. Okay, so let's move on into our last section, and then we'll wrap here. Antenatal testing. Now, the ACOG bulletin on this, and I keep mentioning ACOG or AWAN, it's because NCC, as I talked about in the first webinar, they like to take questions they have to take their questions from documents within the last couple of years, and they like organization documents. They love guidelines for perinatal care. Obviously, there's a new edition every couple of years, so these are great resources that are considered the gold standard of practice. And so for antenatal testing, there hasn't been a current ACOG bulletin for a long time. I think it was 1999. So a lot of folks consider this paper from the Green Journal, this executive summary from the NICHD workshop, to be sort of the white paper, if you will, for antenatal testing. It's a great paper if you haven't read it yet. There's actually a couple pages in it that have really useful. We used to use them a lot. They list all the different really significant complications, pregnancy complications. It's a table with the birth rate, the prevalence, the antenatal tests that's recommended, frequency of testing, and then also adjunct tests. And so it's a very useful, it's a pretty article here, but there's some pages in it that are really, really helpful that I know some folks take out, laminate, and then use them frequently in practice. A couple key points. What is the purpose? Why do we do antenatal testing? Well, I think we all know that it's to identify fetuses at risk for intrauterine injury or death, so that these adverse outcomes can be prevented. And we know, again, from our webinar number 1, that fetuses whose oxygenation utero is challenged will respond with detectable physiologic signs as hypoxemia or metabolic acidemia develop. And we talked about this. We talked about fetuses as they develop hypoxemia. They shunt oxygenated blood to the vital organs. And we talked about this in webinar 1. And we talked about how kidneys get less perfusion. We can get increased renal perfusion, which can ultimately lead to decreased amniotic fluid volume, which is certainly a marker in our biophysical profile or modified biophysical profile. And then acute hypoxemia, for example, babies will stop moving, and we may see recurrent late deceleration. So again, are signs that we can use, physiologic signs that will be reflected in the heart rate tracing. So now this is from ACOG and AAP guidelines for perinatal care this year, 2013. It's the same as they've always had it. Just a couple key points. I know some of you are chuckling right now as you're reading these, but that antenatal testing in high-risk pregnancies should not begin before gestational age at which the healthcare provider is willing to intervene, and that initial testing is at 32 to 34 weeks. With multiple complicating factors, we begin earlier, and we all know that. And then again, just to be clear, when the clinical condition that prompted the testing process, test, what that is based on the test that's given. So it may be a reactive NST or a negative CST if you still do those, or a normal biophysical profile or modified biophysical profile. And these tests should be repeated until birth, and the frequency really depends on the test and also the high-risk condition. Let's run through these pretty quickly. Fetal movement counting. This is one where it's all based on maternal perception of fetal movement. And we know that a decrease may precede fetal death, but not always. So this is sort of a test that can be used. Note the third bullet point, effectiveness in preventing stillbirths is uncertain. So we use it, a lot of folks use this, however, there is some uncertainty still in its efficacy. And we look for is 10 distinct movements in 2 hours, and that's considered normal. And if less than 10 additional evaluations warranted, again from ACOG. So this is an example of some kind of a kick chart. Some of you have these and give them to women. They're little small charts, and women can use them. There's instructions on the back with who to call and whatnot. I only put this in because occasionally on the test they give a kick chart and have you read it. I don't know what their chart will look like. This is just an example of one where the woman notes, on each day of the week, the time she does it, ideally consistent, and she marks in this particular, she'll mark an X when, or mark it in some way when you get your 10 movements. So it took her 20 minutes, 40 minutes, 20 minutes, 20 minutes. And so obviously if it takes longer than 2 hours, the response is to call the provider and do a chart. It may be laid out differently than this. Second test. Test, and I think we all know this test. This is such a great strip to look at here. Fetal, whether or not you have fetal movement, you get these big accelerations. You can see it on the tracing. Accelerations of the fetal heart rate with or without the woman perceiving fetal movement. And we know that a reactive tracing NST is 2 or more accelerations in a 20-minute window with or without the perception of movement by the woman. And again, similar to accelerations that we already talked about in webinar 2 for interpartum monitoring, with an NST, we look at it and class accelerations the same way. If the fetus is less than 32 weeks, minimum 10 by 10, and if the fetus is 32 weeks or greater, a minimum of 15 by 15 for the peak, baseline, and the duration greater than or equal to 15 seconds. At what is the definition of non-reactive? And again, the agreed upon definition is that the tracing lacks sufficient fetal heart rate accelerations over 40 minutes, and requires further testing. And to keep in mind that there's a lot of considerations of why we may get a non-reactive NST. We've talked about some of these actually in our first webinar as well. Gestational age, or sleep-wake cycles, or maternal ingestion of sedatives, or fetal or CNS abnormalities, or hypoxemia, or even among who's had a few cigarettes, we can see for a little bit of time minimal variability and lack of acceleration. And again, just to be clear that we like acceleration so much that sometimes during NST testing, people will use things like the vibroacoustic stimulator to try to elicit an acceleration. This is a baby that in about 40 minutes, these were the only 2 accelerations. And vibroacoustic stim, heart rate, obviously the baby woke up quite a bit here. And I do want to say that the accelerations correlate with a scalp pH of greater than 7.19. This was work that was in 1984 that was published and by Clark and al. And the important point here, someone asked me about this about a week or 2 ago, do we do scalp pHs? And I want to make sure everybody in this room understands, no, we don't. But the correlation was done back in the 80s that when babies were accelerate their heart rate, their pHs were greater than 7.9, and that number often gets asked on the test as well. The next test to briefly talk about is biophysical profile, the BPP. Physicians know this backwards and forwards. Nursing, just to make sure nurses all understand this is somewhat similar to an APGAR score in the sense that there's 5 criteria that are scored. However, the criteria are different, and in an APGAR score, we score each one 0, 1, or 2. Here with biophysical profile testing, we score them 0 or 2. No odd number. There is no 1. So sometimes your patients will, the labor and delivery nurse will do the NST, and patients may go to radiology or ultrasound department for these other 4 markers to be scored, and radiology may call back to the nurse's station and say she has 8 out of 8 or 6 out of 8. If you ever get a call back, which I have, where they've said we have 7 out of 8 or an odd number, somebody's not scored this correctly. So it should always be an even number. So it's NST, fetal breathing movements, fetal movement, fetal tone, amniotic fluid volume. Now, the top 4, the first 4, are acute markers for the fetus is doing, and the amniotic fluid volume is a chronic marker. It's the only chronic marker of these 5 markers. It's a picture of a fetus breathing on color flow. And then the scoring, 8 out of 10 would be reassuring or normal. And then equivocal is usually considered 6, and non-reassuring would be 0 to 4. And the big point that I wanted to make on this slide is that irrespective of the score, a woman has premature rupture of membranes, oligohydramnios may delivery in term pregnancies or more frequent antepartum testing. And so this is important medical management decision looking at oligo. Another slide I wanted to make sure everybody understands is when you look at those first 4 acute variables that I talked about, not the fluid volume, that's a chronic, but the acute first 4, as the fetus develops hypoxemia or hypoxia, the first sign will be fetal breathing movements. They'll lose fetal breathing movements. Then they'll lose about the same time loss of acceleration, maybe fetal movement. And the last marker to go would be tone. So if fetal tone is lost, it's extremely concerning about hypoxemia as well. And the next test is the modified biophysical profile. Here, one of the chronic markers is selected, which is usually the NST. It's the easiest for us to do in labor and delivery. It's a great short-term acute indicator of fetal oxygenation. And then a chronic marker is, again, fluid volume, and it's used the AFI. Together, the NST and the AFI are used. If you have active NST and an AFI of greater than 5, the modified biophysical profile is considered normal. Test. We only have 2 more to go. The CFT is based on the response of the fetal heart rate to uterine contractions, and we don't see this test done very often anymore, but I think we need to know about for the test. Maybe you look to try to get you illicit contractions by oxytocin or by nipple stim, trying to get 3 or more contractions in 10 minutes, each lasting 40 seconds or longer. They're scored as being negative, positive, equivocal, or unsatisfactory. And this would be an example of a negative CST with adequate contractions and no late or significant variable decelerations. Definition: positive with late decelerations following 50% or more of the contractions. Equivocal if there's some different, other decels that are occurring, or unsatisfactory. The one I wanted to mention to you just really briefly is umbilical artery Doppler flow, and this test is an outline, not an NCC's outline. However, I know they've asked a question about it occasionally in the last year and a half, and I just want everybody, docs will know about this, but I want the nurses all to understand that what umbilical artery Doppler flow does is it assesses the resistance to blood flow in the placenta. So just remember umbilical artery, and it's really looking at resistance in the placenta. And the other key point here is that it's the most useful for monitoring early onset growth restriction due to uteral placental insufficiency, for example, in IUGR situation. So that would be the key points to think about. So let's do a few questions. NST in terms of fetus requires? No, it would be 2 accelerations, 15 beats above baseline, lasting a minimum of 15 seconds, occurring within 20 minutes. In profile, the chronic marker for placental dysfunction is amniotic volume. Some kind of chart. There's a lot of different charts out there that are being used. Some of them don't even use an X. They just mark down how many, within so much time, how many movements the fetus has. But for example, with this particular chart, you just have to assess the chart. The fact that it's staying longer than 2 hours, it would be call your OB provider. So the following test results is most consistent with fetal survival within 1 week of the test. That's given here, it would be a negative CST. They like the STEM question, but they change these around a lot. So you'll just have to read through them carefully. The only cited source of adverse outcome during labor. Patient failure. Next question, which was my absolute favorite to show you, which I can't make work. This is a woman at 24 weeks gestation, and it presents with vague complaint of unusual abdominal discomfort, and it would be differential, fetal SVT, previous night's pizza, with garlic or fetal movement disorder, and usually I click on it and the fetus is like driving a car and goes vroom, 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 but I'm sorry, I can't make it work on the setup today, so I apologize. So quick little summary here about test taking. I've talked about it in each of the other two webinars, but in case you haven't seen them, just again, we're supposed to make this a standalone CME 2 credit. So there are 125 questions. 110 will be counted for scoring. Sometimes it's a little bit less than that. They may throw out questions. But the reason that they have this 110 versus 125, 15 questions are embedded pre-test questions, and they're not counted. These are questions that go through. NCC does rigorous work with each of their questions. They go through initially committees of physicians and nurses. They have to have references within the last couple of years to have the multiple references to have the correct answer. And once they've looked at the questions, they put the tests as pre-test questions, and they look to see that the good performers on the test get them right, and that the poor performers may miss them. And if the good performers aren't getting them right, they will never run those questions again. So when you go through the test and you go along and you get to number 10, for example, and it makes no sense to you, just the best answer and move on. It may be one of these questions, and it's not to be counted anyway. And the questions all have a STEM 3 answers, just like I've done for you today. They're alphabetized or in numerical order. There's no penalty for guessing. And then the tracings, I don't know if you'll be taking it online, or in the paper format, they're always set at 3 centimeters a minute, which is exactly like how we see tracing in the United States. It's different in some other countries, but it's consistent with what you and I do in this country. I've never heard of anybody in recent years complain that the quality wasn't good enough for them to determine to answer the question that was being asked of them. And the test, you're allowed 2 hours. Most everybody is done in an hour and a half. The fastest I've seen is 1 hour or so. And in a group of about 100 people taking the test, maybe 10% are still there right at the 2 hours, that are still going back over their answers and, worry about everything. They will, I'm sure those are the people who probably fine anyway, though. So that's the bit I can tell you about test taking, and want to wish you all the very best, and thank Trinity and thank all of you for listening to these webinars. And been just a great. I haven't heard from you at all, so thank you again. And I will try to look at this chat now and see if there are any questions that I can try to answer. Good luck to you all. Thank you.
Questions, again, please put them in the chat. We'll give a couple more minutes for that.
Dr. See anything? Am I supposed to be seeing anything?
Not seeing anything in the chat either. Tanya, do you have anything? All right. Thank you again for an excellent presentation. This concludes today's presentation. Please click the evaluation forms and send them along with your sign-in sheets to Tanya Williams. Again, I listed before that needed to be done by November 21st. Again, thank you for your participation today. And the link to today's playback will be posted to Nexus within the next 24 hours. Have a great rest of the day, everyone. Thank you.
Doctor, you still there?
Yep.
Are we able to hear us, Tanya?
Yes, sir.
Okay.
For the presentation for today, and please sign off.
It's not recording. It's done. Oh, no, you're not on there. I'm here.
Hi, I can hear you in the background.
Yeah, she's
Hey.
trying to figure